Good afternoon, good evening, and good morning, everybody, wherever you listen to this forthcoming edition of our series of webinars. So together with my co-chair, Pavan Reddy from ASTCT, ASTCT and EBMT is presenting another webinar. Today, we choose the topic we have two topics. Actually, we have about CAR T cells and COVID-19. And in the second part, we will how and when to start transplant program in the area of COVID-19 pandemic. So we have selected 4 distinguished speakers. So regarding CAR T cells, we will hear Nirali Shaw from NIH in Bethesda, in the US, and Christian Chabanon from Institut Paoli-Calmette in Marseille in France. And in the second part, we will hear Marco Milkarek from Fred Hutchinson Cancer Center. He will give his presentation about how to reopen the transplant centers. And from the European point of view, it will be Fabio Cittori. He's the scientific director from San Raffaele in Milano in Italy. So I think we will have a very interesting webinar, and I will give over to Pavan to introduce the first speakers.
Thank you, Dr. Kroger. It's welcome to everyone, and it's our pleasure to have fantastic speakers. We'll get started right away. We're going to first talk about CAR T cells in the era of COVID-19. Our first speaker on this is from the American perspective, Dr. Nirali Shah, who comes to us from National Institute of Health at Bethesda. Nirali, take it away.
Well, actually, we switched orders with Dr. Shah, with Dr. Nirali Shah. So if you don't mind, I will just set the stage and start. So I am Christian Chabanon from Marseille, and currently acting as the chair of the Cellular Therapy and Immunobiology Working Party at EBMT. And I will make a short presentation to start the webinar and initiate the discussion, and then Dr. Nirali Shah will provide a US point of view on the same topic and bring additionally her expertise in the care for pediatric patients. So the objective for this first part is to describe the risk of treatment with CAR T cells during the COVID-19 pandemics, and to describe and discuss prevention measures that can be taken during these pandemics for patients undergoing CAR T cell treatment. And let me first start that we really need to remain very humble in this process, because we lack strong and robust evidence of the best decisions to make in many situations. Just as a simple reminder, what is the role of CAR T cell therapies in 2020? Labeled CAR T cells are 2 at the moment. They were approved in the US in 2017, and a year later in Europe in 2018. We have 2 products that are autologous CAR T cells targeting CD19 and thus indicated to treat patients with advanced relapsed refractory B-cell malignancies, acute lymphoblastic leukemia, both in pediatric patients and young adults up to the age of 25 years old, and high-grade non-Hodgkin's lymphoma in adult patients. And even outside the context of COVID-19 pandemics, patient selection is a key aspect in the process to successfully deliver efficient treatment with CAR T cells. These 2 approved products, Tisagen letlocel and axicabtagen tilolocel, are now part of standard of care for these 2 subgroups of patients. Next slide, please. On top of the 2 labeled CAR T cells, there are a high number of clinical trials that were running and open to inclusion when the pandemic started at the beginning of 2020. But these are investigational CAR T cells, most of them still targeting hematological malignancies. A few of these immune effector cells therapies target solid tumors. By definition, they are not approved, so they are not part of standard of care. And as many of you have witnessed, the conduct of international multi-center clinical trials was stopped, and the trials were placed on hold by sponsors, especially by pharma companies that sponsored these trials, because the conduct of multi-center clinical trials heavily relies on worldwide capacities for data capture and monitoring and for sample shipments, and these were heavily disturbed when the lockdown was established in many countries, both in Europe, in the US, and in the rest of the world. Next slide. There are two aspects to consider when thinking of treating a patient with CAR T cells nowadays. One is the supply chain for CAR T cells, and the other one is conditions for treatment of patients and housing patients in hospitals or nearby facilities. The supply chain for CAR T cells is somewhat complex, involves the cooperation between the pharma companies, the manufacturer, and the hospital site. Even in normal times, the turnaround time to T-cell cells or axi-cell manufacturing is an issue, somewhere between 3 and 6 weeks, and physicians who care for patients candidate for treatment with CAR T cells know how complex it may be to care for those patients who may need bridging chemotherapy while the product is being manufactured. So it's even more complex in the context of the pandemics. But so far, from what we know from most active programs and most active centers, the pharma companies were able to maintain the supply chain and deliver the autologous CAR T cells when they were ordered by the hospital. So the limitation in the supply chain may come in some instances from the hospital or the blood bank that provide the starting materials, the autologous blood mononuclear cells that are used to start the manufacturing process. Shortage of personnel, shortage of supplies must be carefully checked before a patient can be started on a CAR T treatment. It's quite reassuring that as far as we know, and up to now, there has been no shortage of critical supplies, including the apheresis reagents and all the reagents necessary for cryopreservation. In the case of T-cell cells, the cells are cryopreserved on site before being shipped to the manufacturing site. And the shipment to and from the central manufacturing organization has been maintained and remains effective even at the most difficult time of the pandemic. The role of patient testing and product testing needs to be further assessed, of course, and that will be further discussed by Dr. Shah. Patient testing is necessary, and no one wants to administer CAR T cells to a patient who is having active infection or even being asymptomatic but infected with COVID-19. Whether there is a risk of transmission through the product remains very unclear in the context of allogeneic transplantation, and is probably meaningless in the context of manufacturing an autologous cellular therapy. Next slide. So the limiting factors for CAR T cell treatments at the moment is not so much drug shortage or increase in the turnaround time to medicinal product availability, then the hospital resource availability. Is there room in the hematology ward? Can you have access to the intensive care unit? Can you have access to tocilizumab and other inhibitors that can be used if patients develop cytokine release syndrome or ICANS. All of these questions need to be addressed depending on your local organization. And of course, there is no general rule, no one size fits all for these very difficult questions. But we'll hear from the next speakers that even at centers that were dealing with high numbers of patients affected with COVID-19, many of the transplants programs and the CAR T-cells program were still running while the hospital was facing the high number of patients affected with COVID-19. And again, there are a number of uncertainties on how to best test patients before they get CAR T-cell treatment. There are limitations in PCR tests that detect the virus, as well as limitations in serological assays that are now coming to the market. And we don't exactly know how protective, for example, are IgG when detected in patients who were previously tested or suspected of being infected with the SARS-CoV-2 virus. To conclude my presentation, and before holding the podium to Dr. Shah, this is the facsimile for the recent publication from the European Society for Blood and Marrow Transplantation, providing recommendations for the management of patients candidates for hematopoietic cell transplants, their donors, and for patients undergoing CAR T-cell therapy. Thank you for your attention, and now it is Dr. Shah's presentation.
Hi, everybody. So I'd like to start off by thanking my co-presenter for that nice introduction into the considerations for CAR T-cells. And I'd also like to thank the organizers for the opportunity to present at today's webinar. So as mentioned, the delivery of CAR T-cells during the COVID-19 pandemic requires thoughtful consideration, and ultimately we want to be able to safely and effectively deliver CAR T-cell therapy, but that does require a multidisciplinary approach, particularly during the COVID-19 pandemic. There is a recent publication led by Bajanova et al. That I've referenced here. And they've nicely highlighted some of the main considerations, which include also the underlying disease, what the local epidemiology is, what the local resources are, as were recently mentioned. Where is your ICU? What is their capacity? Are there blood bank shortages? And what do you need in terms of transfusion support to effectively get your patients through CAR T-cell therapy? And the supportive care provisions. With speaking to who is available, who is going to be on site. And our approach here has been really careful planning with timing of patients, and even potentially thinking about staggering them as we may anticipate when they may go into cytokine release syndrome, with effective communication within the clinical center here so that we are all aware of the current needs in light of COVID-19. Next slide. So here are some general guidelines and practice parameters prior to proceeding with lymphodepletion. These are adopted from both combination of the EBMT as well as the ASTCT guidelines. So for asymptomatic patients who have no known exposure, we do SARS-CoV-2 test screening prior to initiation of lymphodepletion. For those who've had a high risk exposure, or there's a really high prevalence in the community, we initiate the testing, but should have some consideration of potential delay of 14 to 21 days prior to initiation of therapy. And also keeping in mind to consider some interim disease-directed therapy to allow for its delay for more definitive therapy with CAR T-cells, if that's feasible in the patient and their underlying disease. For those patients who are symptomatic, and by symptomatic it means not just respiratory symptoms, but any of the host of symptoms that could be a manifestation of COVID-19 disease, again, SARS-CoV testing is performed. Defer initiation of therapy until the patient is asymptomatic, has a negative SARS-CoV PCR ×2. And if somebody is COVID positive, we would defer initiation of therapy, await resolution of symptoms, and again, try to see if we could have 2 negative screens, again, keeping in mind that there are some false negatives. And of course, I think before you initiate lymphodepletion, particularly for those commercial products where you are sending the apheresis product out and waiting for the CAR T-cell product to be in-house, you would want to ensure that the CAR T-cell product is manufactured, has met release criteria, and is on-site prior to initiation of any lymphodepletion. Next slide. One of the complicating factors in terms of patients who do proceed with CAR T-cell therapy is the ability to distinguish cytokine release syndrome from manifestations of COVID-19. Keeping in mind that cytokine release symptoms may overlap with the presentation. You'll have elevated inflammatory markers, fever, cough, and potentially pulmonary findings, including radiographic findings that may potentially be worse in those with underlying pulmonary malignancy. Our practice is to notify infectious disease colleagues in advance. Again, our patients would have been pre-screened for COVID, keeping in mind that there is some degree of false negativity rates. But keeping them informed prior to initiation of therapy and what the expectation would be for timing of cytokine release syndrome. And of course, the challenge is balancing the practical management of cytokine release syndrome in the midst of a pandemic. Next slide. So I'll walk you through a recent case that we had. Next slide. So this is a 9-year-old female with relapsed refractory acute lymphoblastic leukemia. She received CD1922 CAR T-cells on her phase 1 clinical trial. Her clinical course was such that she developed fever on day 1, and this is consistent with the onset of cytokine release syndrome. On day 4, she continued to have persistent symptoms. At this point, her Tmax was 41.3, and she started to develop hypoxia. Her oxygen saturations reached as low as 90%. She had a mild cough. She was started on supplemental oxygenation, as receiving 1 liter per nasal cannula. She had a chest x-ray performed, a portable chest x-ray that did not show infiltrates. And of course, the immediate thing that came to everybody's mind was stat COVID testing ordered. And folks on the clinical survey started to think about moving her to the COVID floor. But of course, we also have to be mindful that this is a patient who is at the peak of her cytokine release, and really what needed to happen was to have statocilizumab administered while also undergoing the evaluations for COVID testing. And I think that this very nicely illustrated to us some of the challenges when you have patients who are being treated, where you need to think about your optimal management of cytokine release syndrome and the prioritization. This patient ultimately ended up staying on our current floor, had repeat testing done, and had a resolution of her cytokine release syndrome and a good response following administration of tocilizumab. But keeping in mind that these are complications during cytokine release syndrome. It gets a little bit more murky when you start thinking about patients who are now entering the post-CAR therapy period and who are immunocompromised. And that a negative COVID screen may not be completely accurate. So I think you need to monitor for symptoms outside the context of cytokine release syndrome. You need to monitor for diarrhea, fever, and respiratory symptoms. And then keeping in mind in this case, given the right clinical context, even with the false negative result, these may warrant further evaluation. There was a recent adult patient at the clinical center who had 2 negative screens, had presented with some respiratory symptoms, and that continued to progress. Ultimately, a bronch was performed, and the BAL showed a positive COVID. And so I think this reminds everybody that you have to practice with abundance of caution, particularly in these post-cell therapy patients who are immunocompromised. In terms of pediatric specific conditions, you have to remember that the symptoms may present differently. There is, of course, the concern for the asymptomatic carrier states being higher in pediatric patients. The care provider and the rules that have been implemented by many centers really tend to limit who the care provider is, limitations on switching care between those care providers, thinking about how to test and evaluate for exposures of the care providers. And I will say that for most of our families, this has been really been a source of significant stress and not being able to switch with another parent or another care provider while being at the bedside of their child who's undergoing this acute therapy. There's been a lot of questions that we have fielded about siblings and extended family members. You know, in pediatrics, I think we try to be very supportive of having people involved with the care, but we've had to be very strict. And I think that psychosocially, this has been extremely difficult for some of our families, but I think we all want to do what's best, keeping in mind that we're not only protecting the patient, but we're protecting the institution and everybody else who's going to be involved in undergoing further care. There are a host of psychosocial considerations, notwithstanding the issues of care provision, but also just working under the environment that is a little bit more stressful. Thinking about travel, so again, a lot of the places that are going to be doing CAR T-cell therapy, they tend to be tertiary centers where patients may be coming. And so how do you facilitate travel? How do you think about their travel? Is it safe to travel? And of course, you know, most of the pediatric patients are still dealing with acute lymphoblastic leukemia, and so their disease may not hold steady. And so trying to navigate that also is a consideration. My co-presenter talked about commercial products, but again, there are several institutions where clinical trial and having access to clinical trials is still important. In balancing the research elements and what research studies can and cannot be performed, I think becomes an important consideration. And then lastly, which serves as a nice bridge to the next set of talks, is that the role of CAR T-cell therapy in children and what the conversations are with the families. For some families, CAR T-cell therapy in the context of ALL is used as a bridge to transplant. So not only are you thinking about the provisions and the timing of CAR T-cell therapy, you're also having to think about the timing of transplant and want to be sure that you're being thoughtful about where they're going to be transplanted and whether that center is going to be able to transplant them in a timely manner, and how that factors into the decision regarding timing. Next slide. Additional considerations. So keeping in mind that tocilizumab is being used both in clinical trials as well as off-shelf for patients who have COVID-19. We try to be sure that we communicate with our pharmacists to make sure that for proceeding with CAR T-cell therapy, that there are at least 2 doses available. In terms of supportive care, I'll refer you to this table, which is also from Bachnova et al., thinking about what is the care delivery, what education can we provide, how can we do telemedicine to limit outpatient visits, thinking about infection prophylaxis, because certainly you don't want to have these patients get infection on top of potentially having COVID-19. And I'll end this set of presentations with a quote from one of our patients, who basically said to us, as we started implementing the COVID-19 rules, that we have been living our lives as if there's been a pandemic since the diagnosis. And I think that it was a poignant comment in terms of learning from our patients. So our patients have cut back on having people visit them. They go out wearing masks all the time. They've been living in some degree of having social isolation and social distancing. And I think that it was really noted that they were teaching us a lot about how to maintain these parameters. And so I think we have a lot to learn from them. Next slide. Again, a whole set of resources, both with the EBMT and ASTCT. But I will end here and hand it off to the next set of speakers. Thank you.
Thank you very much, Dr. Narali Shah and Dr. Christian Chabanon. So this was the first part of our webinar. And for our attendees, if you have questions, please use the chat and write down your questions. And at the end of the session, we will try to answer your questions. So now we will continue to the second part of our webinar, and this is more or less dealing with Restart Transplant Program. And this is because in some areas, especially in Europe, but also in parts of the US, the infection rate of COVID-19 is slowly going down. So many centers now considering to restart the transplant program. So the first speaker from Fred Hutchinson Cancer Center will be Marco Milcharek. So please, Dr. Milcharek.
Thank you so much, Dr. Kroger, Dr. Reddy, for giving me the opportunity to share our experience here at the Hutch, how we have tried to restart our program. I think it's clear that high-level evidence how to do this is somewhat limited. So there's really no standard approach. So to give you just an idea about the situation in Washington State, you may remember that the first COVID case in the United States was actually here in Washington State back in January. The first death also occurred in Washington State in late February, associated with a patient in a nursing home in Kirkland, 20 miles away from Seattle. Then in the middle of the month, schools and essential businesses were closed and the governor gave a stay-at-home order. And this order is still in place as of today and may or may not get lifted towards the end of the month. I think it may only get lifted in certain counties. This slide shows Washington State population 7.6 million. You can see the red dot, which is Seattle. The blue areas are the counties with the highest COVID incidence, basically the counties surrounding Seattle. Seattle is within King County. The state overall had about 20,000 confirmed COVID cases, had more than 1,000 deaths, which translates into a case fatality rate of 5.5%. And King County itself, so the county where Seattle lies in, has 30% of the population, had 40% of COVID cases, 52% of COVID death, which is the case fatality rate of 7.1%, and had 25 deaths per 100,000 of population. And just to put this in perspective, this is about a fifth or a sixth of the population death rate compared to New York State, for example. Next slide. This shows in Washington State over the last several months the new cases per day on top, and at the bottom the daily death related to COVID-19. You can see cases and death increased and then peaked in early April. You can also see that as of March 6th, we implemented a number of efforts. We implemented arrival restrictions. We pretty much suspended all clinical trials. We fast implemented many telemedicine opportunities, and we also implemented an incident command team that initially met twice a day. Then, as cases and death have been trending down more recently, we started a phased ramp up. On April 27th, we initiated phase 1 of that ramp up, which means we are arriving approximately 30% of our typical number of patients. And then as of May 18th, we're up to 60%. Next slide. And this is what has happened in terms of our census of adult transplant patients in our system. After implementing the arrival restrictions, you can see compared to cases in early March, our census has decreased by approximately 50%, which is quite substantial. And now after the ramp up, you can see we're kind of going through this census nadir, and the census has begun slowly to increase again. Next slide. So what's the right timing for reopening? I think, again, there's no standard of care in terms of reopening, but I think one would want to see a sustained reduction in COVID cases, COVID hospitalizations, and death also in the geographic area of interest. For how long? I think for 14 days, at least, if one wants to kind of follow a little bit the CDC guidelines in terms of opening up states in general. Key resources must be available, such as beds, in particular ICU beds, which tend to be bottlenecks, PPE, sufficient number of ventilators. The testing capacity needs to be in place with a timely turnaround time, and trained staff needs to be available without having to resort to crisis mode if a second wave was to come. Next slide. This shows here the ICU bed utilization over time in Washington State. You can see that utilization increased in early March, but we are fortunate enough that our rate needed of ICU beds and ventilators never exceeded the capacity. The dashed line on top, the green line, is our ICU bed capacity in Washington State. Initially, when the COVID wave arrived here, the projections were that we would be exceeding our capacity, and we put triage teams in place that were fortunately not needed. The National Guard put up tent hospitals in terms of excess resources needed, but again, it was not necessary. And we have been trending down in terms of utilization, and you can see where the ramp up started and where we are today. And projections are supposed to continue to go down. And these projections here are from the Institute for Health Metrics and Evaluation, which is the UW Institute. Next slide. So what about testing? Of course, testing is needed. The motto is testing, testing, testing is needed to protect staff and patient safety. We have an in-house PCR for patients who get nasal swabs, and all transplant patients pretty much from the get-go actually have been tested upon arrival to our service, upon each hospital admission, then on a weekly basis as a monitoring strategy and before any procedure. That at least how we have been doing it. I'm not saying this is mandatory to do it. And then healthcare workers who were symptomatic were also tested, of course, and asked to stay home if they had symptoms. And it's important to have procedures in place for confirmed cases and for patients under investigation. Next slide, please. This shows the number of COVID-positive patients in the University of Washington Seattle Cancer Care Alliance system. So inpatients, you have to understand, they're actually at the University of Washington. And you can see here that in early mid-April, the peak occurred with more than 120 patients in the system, and subsequently numbers have been decreasing. The dark blue bars are the ICU beds compared to the regular beds in lighter blue. Next slide, please. So this shows now the testing results at Seattle Cancer Care Alliance. And I'm fortunate and happy to report that within our Fred Hutch BMT population as of today, we have not had a single patient who has tested COVID-19 positive. And these are 175 unique patients who have been tested, more than 600 total tests performed. And this compares to, if you look at the Washington State population tested, more than 300,000, to a positivity rate of 6.2%. Most of those obviously have been symptomatic. And then the SCCA cancer population as a whole, more than 1,500 tested, for 4.5% positive. And then the SCCA staff, more than 800, 1.5% positive. So we're lucky we haven't had a positive patient. What about personal protective equipment? It's obvious there needs to be a sufficient supply, including what might be needed for a second wave. The staff must be trained of using it. Conservation policies should be in place. And here at the Hutch, at the SCCA, we have a masking policy in place in the clinic, in the hospital, for patients and for staff. Next slide. So now we're in the ramp-up process and we are bringing back patients who have been deferred. So we have been trying to apply some general principles. Who should come first? Who should come back first? So certainly patients who have the highest benefit versus risk ratio. So those who have most to gain from the transplant, who have the least burden of comorbidity, for example, as a general rule. Patient who had already arrived a while ago and then we're told you cannot get transplanted right now, please go home for now, they would get prioritized. And those patients who live in our region also would come first. This summarizes, and I'm not going to go into all the details here, but based on a disease risk categorization, who should come first now? And we have started to implement this. So for example, patients with high-risk AML in a remission would be prioritized. Patients with intermediate or standard risk acute leukemia who are MRD negative and who are tolerating consolidation would be still deferred at this time. And then for the autologous patients, we had deferred most of them actually, but we are bringing back patients with aggressive lymphoma and will also be addressing autologous patients with lower category disease risk very soon. Next slide. So other measures we have implemented to minimize exposure. We have implemented point of entry screening at the clinics, at the hospital, pretty much from the beginning. We have tried to leverage telemedicine. We see about 800 consults, transplant consults per year. And very much from the beginning of March, we have transitioned to telemedicine encounters to minimize risk. We have used telerounding in the clinic, in the hospital, trying to spend as much time using electronic modalities to communicate and then to limit the time needed to see patients, also for the purpose of distancing. Our patients, we try to educate them well. So I think they pretty much adhere to self-distancing measures. We have tried to reduce the density of patients in our patient housing facilities, just in case there could be an outbreak. We've also taken care of our providers, physician attendings, for example, trying to remove them from service because of comorbidity or because of somewhat older age, just to minimize their risk. And we have given our non-clinical staff the opportunity to work from home. Next slide. So just to conclude this, almost how to deal with clinical trials. We have a lot of clinical trials going on at Hutch here. And in the beginning, when this wave was facing us, this COVID-19 wave, and we couldn't really tell where it was going, would be exceeding our healthcare resources, we pretty much put most clinical trials, at least most phase 1 and phase 3 trials, on hold. We have now begun to reopen them in a synchronized way with all our clinical operations. The criteria, which trials should open first, again, risk-benefit for the patients, how much travel is required, number of trial-related visits, ancillary studies needed, the risk to staff. Does the trial need a lot of support staff coming in and out of the hospitals? The likelihood of straining clinical resources like ICU beds, PPE. How scientifically impactful is the research conducted in this trial? And if a tiebreaker was needed, we wanted to give priority to our junior investigators that their trials should be open first. So to summarize, I think the Hutch transplant numbers have been reduced substantially to protect our local healthcare infrastructure and patients. We had the first case and death in Washington State, to remind you. Fortunately enough, the health resources did not get exhausted here as initially feared, and we have not had a Hutch patient, a transplant patient, who tested COVID positive. I think it's obvious that further delays would likely lead to an excess in mortality because transplant patients might lose their transplant window of opportunity. We have started a phased ramp up because our local regional COVID activity has continued to decrease. We have a pretty robust testing system in place. We have sufficient supplies on hand, and we have a monitoring system in place that we can respond what we are doing if things get worse again. And I think it's clear that institutional ramp-up readiness it varies according to a geographic location, and what I'm presenting here is pretty much Hutch specific. Thank you so much.
So I keep going. So I can start. Can you hear me?
Yeah, please go ahead, Fabio.
Okay, thank you. So next slide, please. So we are late, so I will try to summarize briefly. So our experience. So at San Raffaele Hospital, we have actually faced a spread of the pandemic as one of the first most important area in Italy. Next, please. And next slide, yeah. And as you can see, Milano was not the worst city in the area, but essentially one of the most touched with other cities like Bergamo, Cremona, and Pavia. Next, please. So we actually were facing the pandemic, reorganizing the hospital, and essentially we kept ongoing only bone marrow transplant and hematology, and a cardiovascular hub for heart and vascular diseases. And so we were deeply involved actually in the management of those patients. And despite the full BMT activity was running, we dedicated exactly half of our hematology staff from hematology and bone marrow transplant to the COVID area. Next, please. And essentially, we actually participated to the COVID activity in looking in deep, both in the organization and in the prospective evaluation of patients. And these are the touch of our analysis of the first 500 patients with the definition of the risk factor for the outcome in our patients. Next, please. So we could actually look at some biological indicator of severity. And essentially, we documented across the ages a very important hyperinflammation syndrome in our patient. Next, please. And we could actually look at the survival in our COVID patient differentiation by age and by some risk factor like hypertension. Next, please. And diabetes and actually some radiological parameters at outcome. So actually we participated, and I can tell you that here we have two parameters. One is the LDH and the lymphocyte count that actually were really correlating with the outcome in our COVID patients. Next. And we could perform even a multivariate analysis. You can see cancer, beating cancer, active treatment was one of the risk factor for outcome. Next, please. So one important observation is that across, so we look from the end of February when we started up to now, beginning of May, and we separate into quartiles our population of patients, 1,000 population patients. You see that the mortality in hospital dropped from 29 to 2% in patients. So no doubt the severity of patient presenting and the transferring to ICU were dropping in our population. Next, please. So, of course, we participated to definition of experimental drugs in COVID. Next, please. And essentially, we were actually looking at the endothelial participation as hematologists. We were quite, experienced in the microangiopathies. Next, please. And so we actually focused at the very beginning that would be a very important component of microvascular disease within the lung and multiple organs in defining the syndrome. And so this was a working hypothesis. We looked at the thrombosis in the lung and actually defined that all the thrombotic events were overlapping with inflammatory areas. So just defining that they are not embolism, but that they are thrombotic complication of acute endothelitis in the lung. Next, please. So then we worked on this inflammatory pathway we know, and next please, we worked on complements, and so we actually trained, and now we are now 3 patients treated with a complement inhibition, comstatin and MY101, and it's very, very important and successful treatment in these patients. We worked on of course, IL-1 blockade and tocilizumab blockade, OL6, in our patient with some important results in defining the survival of patients. Next, please. Yeah, so this is the TOCI, and again, please go. And the impact of immunomodulating treatment in survival was part of the observation. Next, please. So actually, I'm quite proud to say that in the institution, the multidisciplinary program from hematology and BMT actually was transferred into the COVID pandemic assistance. And actually, we developed a CLR specific for our patients. We biobanked up to 1,000 patients. And now we have a virological, genetical, and some immunological and biomarkers important observation. So during the COVID treatment, essentially, BMT was running. 100% of patients were and beds were keep going. And the total amount of transplant this year was essentially the same of the past year. So we isolated, I cannot say here, we isolated the area of BMT from the rest of the hospital. Next, please. And essentially, we had no one case of of COVID testing in our patient after this isolation and full activity. Next, please. So if we look more in deep in the Italian national data, I can tell you that in both March and April, the total amount of transplant from all kind of donors, so related and non-related and haploidentical, actually 2020 were huger than 2019. So overall, we can say that the transplant activity across the country was actually kept and without a significant limitation in the activity. And so I think that we have to dedicate to the memory of our Italian healthcare workers who spend actually their lives in the care of patients. It was a huge amount of doctors and nurses who actually died in this, and I would like to dedicate to them these efforts. So thank you very much for your attention.
I think we'll take some quick questions. Let me just collate some of them together. Dr. Kroger and I will moderate these questions. So the first question is Dr. Shah and Dr. Shabana. The question really is, how do you define high prevalence of COVID in community? And do you use CT scans pre-CAR T cells as screening method?
I'll answer the second part first with regards to CT scans. We are not routinely doing CT scans or chest x-rays. That may be due in part to the fact that I treat pediatric and young adult patients primarily, where I think that we haven't seen as much of an issue of symptomatic. I think with regards to prevalence, I think you do have to keep in mind what is going on in the local community. I don't say that there's a number, but I think, when we are very much in line with what is happening within our local communities, our local hospitals, what the admission rates are, what the local incidences of patients going to the ICU with COVID-19. So I do think that there has to be some consideration for individual location site differences in regards to the incidence and prevalence at your particular site.
I am lucky to live in an area that was relatively spared by the COVID-19 pandemic in France and in Europe. The part of France that was highly affected was the northeastern part of the country and the Paris area. So in Marseille, we didn't face that many patients, and I'm also working in a comprehensive cancer center where the rule was to try to maintain the hospital with as few as possible patients affected with COVID-19, because we are only caring for patients with cancer. So we were in a rather, I would say, easy situation, if I can say so, as compared to some of our colleagues. That said, we've used CT scan for some patients who were suspected of having COVID-19, but very few of the patients were actually turned out to be positive for COVID-19. So that's part of the screening procedure before starting the treatment, but that should be tailored individually.
There's another question mainly for Dr. Milkacek, but probably also to Dr. Chicheri. This is, despite the fact that the potential transplant patient or the transplant patient are at high risk of infection, there seems to be a low incidence of infection. Is there any specific reason for this in your mind?
I think there's a specific reason. I think the transplant patients are already kind of aware that they're at an increased risk of infection. I think even before COVID arrived, they have been trying to self-distance, not to get infected during after transplant. And then during this acute period here, we have been slowing down the arrival of new patients who might have come from communities with a higher prevalence of infections. I think a combination of factors contribute that we haven't really had the problem with COVID here within the system. It's to a certain extent, I think it's because of the measures, the reduction of arrivals we implemented, the screening, but also to a certain extent, probably also luck that it hasn't happened yet. And I wouldn't be surprised that in the near future, we might be seeing the one or the other COVID positive transplant patient here in Seattle in our program.
So the next question, I think, again, for either Nirali or Christian, I think both of them can take this one on. It relates to the numerous toxicities from CAR T cells, particularly B-cell lymphopenia. So could you really take a COVID-19 patient through a CAR T cell? I guess the question is, someone's already positive for COVID-19, would you take them through a CAR T cell therapy?
I think our guidance would suggest that you would have to wait until they were asymptomatic and see how the patient was, right? I mean, you are dealing with a life-threatening disease at the end of the day, and most of the patients who are going to be referred for CAR T-cell therapy have exhausted all options. So I don't think that you can come up with a general statement, but I do think that you'd have to take that patient in context of their disease, other available therapies, and weigh the risk benefits of CAR T-cell versus the risk benefit of what additional therapies they would be able to receive to control their underlying their leukemia. And I think that it would be hard to know exactly what to do. But I think as best as possible, you'd want to think about how to effectively support them through this.
I absolutely agree. In general, it is not recommended to treat patients with CAR T cells during an active infection. And the rule is basically the same with COVID-19, plus on top of that, the many uncertainties on how to properly diagnose and guarantee that the virus has been cleared once the symptoms disappear. But definitely, active infection quite risky to embark such a patient on CAR T cell treatment.
We cannot hear you, Nikolaus. Nikolaus?
You can hear me now? Sorry, there is another question similar, is for transplant patients who had acute myeloid leukemia and becomes COVID-19 positive during induction chemotherapy, but then becomes negative. So and there is an indication for stem cell transplantation in remission. So what do you recommend to do before you go for transplant? Is a single PCR sufficient, or would you recommend also to look for complete resolution in CT scan? So what is your experience, and maybe according to your gut feeling, needed to go for transplant in these patients?
I would maybe more speak to my gut feeling, because we haven't had any patients here in the program. But I mean, analogous to what we have been doing with other respiratory viruses, I think, yes, one would need negativity of the PCR twice, I would think. And I would do a CT scan to see what kind of pulmonary abnormalities there might be. So I think we would never have taken patients with active respiratory viruses into an allogeneic transplant who are still shedding virus. And again, this is more gut feeling, not based on a large number of patients treated here. I would not proceed with an allo transplant if patient was shedding COVID-19.
Personally, I can only actually share completely this vision.
Mm-hmm.
So one other question again on the CAR T cell. I think Fabio, perhaps you or all four could take this one on. In terms of, I think the question specifically relates to IL-1 receptor antagonist and how it compares with IL-6. I know there are no data, but maybe you may have some thoughts on which one you would use, particularly in the context of CRS/COVID-19.
Yeah, thank you. So if we look at so we actually treated around 300 patients with anti-cytokine out of our 1,000 patients with COVID in the institution. I can tell you that we had actually no significant difference in the effect of tocilizumab, sarilumab, which is the other one, IL-6 antagonist receptor, and anakinra or mavrilimumab, so the anti-GM CSF. We had essentially the same results in switching off inflammation. I would say that the most potent switch off actually was registered with the complement inhibition. So we had really 48 hours normalization of LDH and all the inflammatory parameters, and a dramatic response. And so we are really convinced and speculating that the complement activation in this specific inflammation induced by virus is really crucial and should be really developed.
Nicholas, I think your speakers again. Yep, thanks.
There's another question. Great to see that the unrelated numbers or numbers holding up. However, are these patients at greater risk going forward if the virus remains prevalent and they develop GVHD? It's more for you, Fabio.
Yeah, essentially, we had no one test positive patient in transplant ward, but actually we had among the first year of follow-up, we have around 100 patients follow-up within 1 year after transplant, and we had actually 6 cases of COVID pneumonia. And this was under immune suppression. They were under cyclosporine or sirolimus. And I have to tell you that no one of them received non-invasive ventilation. So we have the impression that the concomitant immune suppression for GVHD prophylaxis or treatment, as an especially chronic GVHD, actually is somehow protecting for the hyperinflammatory pneumonia. So I would, at this stage, from our experience, but we are trying to collect the Italian experience overall of COVID in the follow-up COVID pneumonia. But our impression from our institute is that essentially that the immune suppression should not be switched off in case of pneumonia, should be kept on, and this is somehow protecting from severe forms of pneumonia.
Thank you, Fabio. I think we just have 1 more minute here, and maybe a quick stab at the future. I think one of the questions is any thoughts on the risk of the second wave of COVID-19 coming along? If I think it's not sure there's obviously any data, but Marco, perhaps you could take that one and just give your thoughts on how you would manage if there's a second wave.
I don't know whether there might be a single second wave. I think it will be very dependent on the region, how the local authorities are dealing with keeping distancing measures in place. I think we're seeing in the United States, we're seeing smaller second waves already occurring depending on states that have lifted distancing restrictions. I think for us here, we're probably a little bit better prepared if there was a second wave in terms of supplies, PPE, how to basically approach things, how to monitor the situation. So we are trying to prevent a second wave as much as possible, but I think we might be a little bit better prepared facing one if it was to arrive.
I think that is the time we have left for exactly at the end of the hour. I want to thank all the speakers. Thank you very much, and thank the participants for participating and asking questions. I'm sorry we couldn't get to all of the questions in dearth of time, but these will be available for folks to watch. Again, thanks to Professor Nicholas Krug for co-leading this. Thank you, Nicholas. And if you want to say some last few words, please do.
No, I just can you hear me?
Yes.
I just want to echo you. So thanks to speakers for the excellent presentation, and thanks attendees for taking care. Thanks Dolores and Isabel for organizing this meeting. Bye-bye.
Bye-bye,
everyone. Thank you all.
Thank you.
Once again, thank you, speakers.